Next up, we have Dr. Corey Detlefs. He's a trauma surgeon at Banner University, Phoenix. He's a clinical assistant professor of surgery with U of A, Phoenix.
Thank you. It's an honor to be here. I'm really humbled, and I've learned a lot today. And it's exciting to see people that are really as passionate about trauma as I am. I want to go over a few things about rural trauma that's a little bit different than what many of us experience, what it is, what the scope of the problem is, which is quite significant actually, and identify some of the challenges and what are our opportunities to help them. This is a picture outside of Chinle, and I had to wait to get gas in my car as this lady took her cows through the gas station. It's open range up there. It can be pretty dangerous. So imagine you're in a small facility. The one on the right side of the screen is San Carlos, and up until they had their new hospital within the last couple of years, they didn't have a CT scan. They had an Xray machine that was probably older than I am, and that's pretty old. The one on the left is Bisbee, and it looks like a double wide, and on the inside it's more narrow than what you see there. Limited resources. This is one of the Xray machines on the right that was at San Carlos several years ago. And this is what happens if I try to start an IV in the trauma bay. So how do you deal with this if you're in a rural community? It's a real challenge. Well, why do we do this? Well, one thing I'd like to say is that Dr. Wachtel was my mentor, and he's the reason that I do what I do. And unfortunately, or maybe fortunately, I don't know, I was there when he came in with his spinal cord injury. And I looked at him, and I said, "Hi, Tom." He looked at me and said, "Hi, Corey. It's bad, isn't it?" And, but he's the reason I do what I do. We all know these figures that trauma really is a leading cause of death. If you look at the Navajo Nation in the northeastern portion of our state, that actually spans 4 states. It's a leading cause of death up to age 55. And for all causes of death in the Navajo Nation, for trauma, it leads every other population in our state. A lot of productive years of life are lost, and we know that we can make a benefit. That an organized system improves outcomes for these folks. And it was touched on before, but the zero preventable death from injury goals from a variety of organizations, the Committee on Trauma has really taken this seriously. So rural needs to be included in that process for us, and we have to find better ways of accomplishing that. So what is rural? There are multiple definitions, but if you think about it, even our hospitals can become rural in the event of a mass casualty event, such as 9/11 in New York City. It can be isolation, defined by geography or distance. The facility that you see in the picture is Palaka. It's the Hopi Reservation, which sits inside the Navajo Nation, and they don't have surgical capabilities there. It's a great facility. They do a great job with the limited resources that they have. One of the biggest things is professional and facility resource limitations, and that's something that many of us don't really appreciate. Well, if you look at what happens if you're injured in a rural area, and who of us isn't really a rural citizen when we're traveling throughout the state, going to California, Las Vegas, but there's a higher mortality related to injury. It's at least twice that for unintentional injuries. And oftentimes, people that die in the rural environment have less severe injuries, and they're therefore potentially preventable if they got to the right place at the right time or the right resources were brought to them. So in Arizona, about 15% of our population is considered rural. And national average is about 20% of the population is rural, and the other 80 is in an urban area. Yet 60% of the injury mortality associated with motor vehicle crashes happens in rural areas. So again, emphasizing that you're more likely to die if you're hurt in a rural environment. 25% of people who live in a rural environment, at least in our state, are likely to be injured at some point during the year. That's not a small number. If you look globally, the Committee on Trauma has taken the stance that a lot of the things that I'll talk about in a few minutes should be available worldwide. If you look globally, low to middle income countries, the population is reversed. 80% of the people live in rural areas or frontier areas, as I learned from the Trauma Association of Canada. And that's a significant burden and contributes to a major cause of death worldwide, what we do every day. Why such a difference? Road conditions. In the rural areas, people tend to be speeding more. Weather may play a factor. I'll show you some slides in just a second. As far as behavioral, well, I'm not sure I agree with this. It's more likely that folks in a rural community are going to be compromised by alcohol. I can't say that's my sense in the patients that I see here, as it seems like many of them are impaired by alcohol. The use of restraint systems, whether child restraints, is worse in the rural environment. Opportunity there. For the United States in particular, agriculture and mining contribute to this, but one of the things that we teach and espouse in trauma is time to definitive care. That's a big issue with regard to this. This is open road. This is on the Navajo Nation. So imagine this is a 2-lane highway, and people are driving on this at nighttime, 50, 60 miles an hour or more, and you don't realize that this herd of horses is crossing. I've had people that have been injured by running their motorcycles into goats, into cattle. It's a significant problem. Please be careful when you're in rural parts of our state that realize what an open road means. Communication is an issue. I was in White River several years ago, and maybe it's that I don't know how to use my phone very well, but I tried to dial 911 just to see if my phone would work. I'm not on the same system that IHS, that the reservations are on. My phone would not work. That was quite troubling. I had to use someone else's phone to make a phone call to home. The distance that's necessary for EMS to respond can be substantial. We take for granted what we have in the urban areas. Our response times are in the matter of minutes. Well, it may be 40 or 50 or 60 minutes in some of the rural areas, at least in our state. It can be even longer if you go to places like Alaska, where people are hours away from any kind of help. Pre-hospital availability, education and training. What happens in parts of our state is that EMS providers go to paramedic school, they're hired by some of the aeromedical companies, and they're offered a great deal more money to work for them than they make working in some of the rural communities. So the paramedics, and I was a paramedic in LA in the early days of the paramedic program, before a lot of you were even born, actually. But they don't stay. So who responds in the rural area is quite variable, but can take a long time. And again, resources of the closest hospital. This is a picture of the bus from Mexican Hat. And this was, 10 years ago now. The bus was returning from Colorado after a holiday ski trip, and they were on a road that the driver was unfamiliar with. It was nighttime, so it was after dark. There was snow on the ground, wet roads, and one of the only reasons I was told that they were identified as having the crash is somebody watched them fly off this 41-foot embankment. Cell phones didn't work in this area very well. The first person to make a call, by one account, actually drove to a city where she could use a payphone. But she thought it was just a truck that had gone over. So the EMS response was limited. Subsequently, they realized it was a bus with many people, and people were transported to rural facilities, including Kayenta. And Kayenta, just within the last year before that, had actually closed its emergency department because of lack of staff at nighttime hours. And subsequently, a lot of those patients were transferred throughout. So what can we do to help rural victims and facilities in our rural population, especially as we try to approach zero preventable death? Well, we need to understand the limitations of rural areas. They know what they can do. My contention, which isn't held by everyone on the Committee on Trauma, especially the Rural Committee, that is one of the committees that I sit on, my contention is that if I get a call from a facility, it's not my position to judge what they can care for and what they can't. They know. My responsibility is, how can I help? That's not held widely. Thank you. Thank you. Be a resource for them. One of the things that I tell rural facilities when I go out and teach and visit with them is, even if you're not going to send the patient, but you want to know what to do, or maybe you think maybe you don't need to send the patient, call me. We can talk about it. And the Committee on Trauma realizes that maybe our triage guidelines need to be modified some. But there are a lot of facilities in our state and in rural communities where the providers really don't have the experience to care for injuries. So we have a lot of opportunity for them. Please readily accept patients. If you're called, they want to send somebody, accept them. One of the logistic issues, whether it's financial, medical, legal, I can't tell you this, is that EMS or aeromedical services frequently will not respond, and they may have to respond quite a ways to get to a rural facility to pick up a patient until you have an accepting hospital, bed number, and physician. Anything you can do to decrease that time from injury to definitive care is in the best interest of our trauma system and the community that we serve. Educational efforts. These are some of the educational efforts that everyone's familiar with. One of the things I learned about that I hadn't heard about before was definitive surgery for trauma care in a paper out of Canada. This program has been given to many places where there are surgeons who perhaps don't have a lot of experience in trauma. And it sounds like a nice course for them to learn how to at least do damage control, surgical things, stop the bleeding, and then get them transferred into rural areas. I actually do have a disclosure. I'm part of one of the authors of this course, and it's been a wonderful experience for me for a lot of years. And this is a paradigm shift, and this is a paradigm shift that the Committee on Trauma, that the American College of Surgeons has accepted. And that is rapidly evaluate and manage these patients to the best of their ability if they're in a rural community. Deal with the ABCs, know what you can take care of and what you can't, and they know what they can take care of and what they can't. And then initiate the transfer process within 15 minutes. And I feel guilty. I feel like many of us in the urban areas are so busy that when we get a call from a rural facility, our attitude is, well, I'm too busy and I don't understand why you can't take care of this patient. So they try to sell the patient. And how do they do that? Well, they get a CT scan, even though they can't act on that CT scan. There are very few rural facilities in our state have surgical capability. Very few. Many of these places are clinics that may be open just a limited time that happen to see the trauma patient. So asking them to do studies they can't act on delays the arrival of that patient and potentially causes more harm to that patient than good. So it is sponsored by the ACS. It really focuses on them knowing their resources, but it's about their team. It's creating a team with assigned roles and responsibilities. And again, transfer process early. The course is rapidly proliferating. It's actually in 3 countries now, and we've done more courses throughout. Each year, the number of courses, the number of students taught is much better. At one course early on in this process, I actually had a member of a tribal council, not a medical person, who was there attending the course, trying to understand how they can participate on a legislative or on a governmental level for the Navajo Nation, how they can help with this. But it really emphasizes planning and preparation. Well, there's not a lot of science. I know we heard earlier about, do some of these things help? Does injury prevention work? There's not a lot of data with respect to RTTDC. We do know that it does shorten the length of time that a patient is in the ED before they're transferred, and the time to call for transfer is reduced. It's oftentimes not reduced to 15 minutes. It isn't, so we have room to work. In this one particular study, there was no difference in pre-transfer imaging. So they did a bunch of X-rays or CT scans that they couldn't act on that potentially delayed the decision and the actual transfer. A study out of Parkland, it was well perceived as a good educational tool for rural nurses. There was actually retention of information at 6 and 12 months in this study. One of the earlier participants in this, Dave Kappel, added a communications module that helped. And they were able to demonstrate that with that, they actually improved the transfer process and reduced the transfer time. What can we do? We can support these rural facilities and be a resource for them. I can't tell you, I learn more from them than they learn from me when I go out to these facilities. And they do an amazing job, and they are absolutely committed. Rapidly accept their patients, don't delay their transfer, or by asking them to do studies that aren't going to change what they can do for the patient, especially if it delays the transfer of the patient. And realize that they're part of our trauma system. Other ways to help: injury prevention, use of registry data to find opportunities, shadowing. Dr. Reese several years ago, and I think it's better to ask ask forgiveness than to ask for permission. When we tried to take telemedicine out to some of the rural facilities, the attorneys heard about it, and it kind of got stopped for stark reasons, I think. But what Dr. Reed did was he put cell phones, HIPAA-compliant cell phones, in a variety of facilities, and those facilities had the ability to call the trauma surgeon in Tucson and talk to them, and maybe show them pictures of the patient or X-rays. I think there's opportunity there that we really need to work on. Lessons I learned: they're so appreciative if you come out and show that you care and that you're there to help. And it does make a difference, and they are part of our system. These folks do a great job, and we really have I tell them I live in Disneyland. I've got too many people that respond to trauma activations. And we have no idea what they have and what they can do. And we need to be supportive. And as I said, they're very committed to this process. By the way, they are everywhere. This was outside of Chin Lee a couple of years ago. I was up there a few years ago. If you can't read it, it's Injury Law Center. I was up there a few months ago. It's gone. I'm not sure why, but it's gone. But they're everywhere. This has been an honor for me, and thank you very much for the opportunity to talk.